take all of me? All of me, why not take all of me?
Unser ganzes Leben ist voller sehenswerter Augenblicke. Schützen Sie diese bei trockener, altersbedingter Makuladegeneration. Ocuvite Macula mit dem patentierten Vitaminkomplex aus B6, B12 und Folsäure. Nur eine Kapsel täglich unterstützt Sie bei trockener AMD. Ocuvite, weil das Leben sehenswert ist. Unser ganzes Leben ist voller sehenswerter Augenblicke. Schützen Sie diese bei trockener, altersbedingter Makuladegeneration. Ocuvite Macula mit dem patentierten Vitaminkomplex aus B6, B12 und Folsäure. Nur eine Kapsel täglich unterstützt Sie bei trockener AMD. Ocuvite, weil das Leben sehenswert ist.
Hey everybody, DJ Cozy is my name, and I rock the microphone, and I'm fame. I'm easy to grow and rock the mic, yeah. What's up, Joe? Check the flavor, yeah.
Unser ganzes Leben ist voller sehenswerter Augenblicke. Schützen Sie diese bei trockener, altersbedingter Makuladegeneration. Ocuvite Macula mit dem patentierten Vitaminkomplex aus B6, B12 und Folsäure. Nur eine Kapsel täglich unterstützt Sie bei trockener AMD. Ocuvite, weil das Leben sehenswert ist.
as words settle in the depth. Nature molds time, a life's journey along the sweet banks of Jordan. Immortal being lounges on honey-fringed thighs. Cocoa shine her raven hair, trailing oriental scents and a hot, dry air. Sunlight dances bright, all is alive with the light. As splendid wings spread out to fly, we kiss desperate worries goodbye. The fresh dew of new days to come, a burst of joy and songs we sung. Rich golden melons rest on their banks. This is the day we are all alive. Give thanks. Rain, rain in April today. Summer is here to stay for a while. May comes into rain. April.
I've been waiting for the chance to break it down. Gotta cut through the noise, gotta make it loud. Gonna watch me rise above the crowd. I'll leave it all down on the ground. On the ground. Can't stop it now. Can't hold me down.
Unser ganzes Leben ist voller sehenswerter Augenblicke. Schützen Sie diese bei trockener, altersbedingter Makuladegeneration. Ocuvite Macula mit dem patentierten Vitaminkomplex aus B6, B12 und Folsäure. Nur eine Kapsel täglich unterstützt Sie bei trockener AMD. Ocuvite, weil das Leben sehenswert ist.
Is here to stay just a little longer. Thirst quenched exotic dreams of ours and oozing, dripping on silken smooth skin. Dreams come true. Through blurred visionary hours appear crystal clear. The sunshine of her purest flower. Reality, she comes on me. Her voice no longer a mystery, no longer an invisible thing. Welcome, darling of the spring. May bring in April today. Summer is here to stay for a while. May comes into rain. April is here to
All of me, why not take all of me? Can't you see I'm no good without you, babe? Take my lips, I wanna lose them. Take my arms, 'cause I never use them. Your goodbye left me with eyes that cry.
Hello, good morning, good afternoon, good day. I wish you a very nice getting together with us here in Cologne. Greetings from Cologne. And I'm very proud and happy to present the debate for you. This is an online event, an international online event, and we have world-leading experts discussing the topic of corneal ectasia, each with their outstanding expertise and looking at this problem from a different perspective. And in the first part of this program, we will follow their presentations. We have 4 presentations to present to you. And thereafter, we will discuss with our friends and experts, and we will try to spot those areas where we have not the same and mutual agreement on some questions, where we'll try to find the areas that are lacking of a little bit of knowledge and where we have to be more, where we have to learn more about the problem of itself. So beside me is sitting Georg Gerten, my colleague and partner here in Cologne. And Georg will introduce our first speaker, which is Damien Gattinel. Georg?
Yeah, thank you. Thank you for the introduction, Omid. And now it's a pleasure for me to introduce Damien Gattinel. He's the head of Anterior and Refractive Surgery, Department of the Rothschild Foundation in Paris, France. And he's not only an excellent surgeon, but also an inventor. He was contributed to the invention of the first trifocal IOL, and he also developed an AI system for the detection of ectasia susceptible eyes, the so-called score analyzer, and I'm very much looking forward now to what he has to say about corneal ectasia. Please, Damien, can you hear us? But we can't hear you.
Yes, I do.
There you are. Okay. Okay.
Nice to see you.
So why don't we go forward with your presentation, Damien?
I think I sent it, so you.
Okay, we just
to
have
launch
to
it. It's recorded.
launch it.
Yeah.
Okay.
I would first like to thank Dr. Omid Kermani for organizing this debate with my colleagues and friends Dr. Renato Ambrosio and Farhad Afizi. I'm convinced that the confrontation of ideas and points of view will enrich our knowledge. I also want to thank all my collaborators. I wouldn't dare take 15 minutes of your time to explain to you that eye rubbing is a risk factor for keratoconus. The existence of exogenous traumatic factors had already been pointed out by Nottingham in his memoir. Since then, there is not a published study on the risk factors for keratoconus that does not mention eye friction. Like this other paper published in the British Journal almost 50 years ago. The thesis that I support is that rubbing is not a trivial risk factor, but a causal risk factor, define as shown a condition without which the disease would not have occurred. In other words, unlike the classic thesis which states that there are multiple risk factors, and by risk factors we mean that they are optional, I maintain that excessive rubbing is the first essential cause. There is of course a favorable genetic environment, but keratoconus is not primarily a genetic disease. It is a behavioral disease. Excessive rubbing is necessary, sine qua non, but its action may be triggered and or potentiated by certain genetic cofactors. The stake of this debate is not only academic. If this conjecture, which can be described in 11 letters, no rub, no cone, is true, then there is tremendous hope that we can not only halt the progression of this disease, but prevent it from occurring. These observations suggest that the strict cessation of excessive rubbing could allow a certain regularization in children screened at a very subclinical stage. I'd asked for a topography in this allergic child who did not complain about anything but demonstrated how he used to rub his left eye chronically and noisily. Any allergic child should benefit from systematic topographic screening and monitoring. Our broad prospective follow-up also confirms to us the merits of the no-rub no-cone theory. None of the stable eyes here have been operated on for cross-linking. They have simply been removed from all diurnal and nocturnal rubbing. All our patients are followed according to a strict protocol, and in subjects who no longer rub, all keratometric and topographic indices are stable. Some of these most representative and inspiring cases are presented online at defeatkeratoconus.com. In my mind, and that of many of my close associates at the Rothschild Foundation, the mystery of the etiology of keratoconus has been dispelled for some time, and I hope you will be the same after this presentation. But one mystery replaces another. How is it that the ophthalmological community remains largely reluctant to a theory which obeys the laws of physics and is corroborated by clinical evidences? This may be because there are some misconceptions that need to be cleared up. These publications. This article has just appeared, which reviews the genetic versus mechanical causes of keratoconus, and which concludes in the existence of purely mechanical pathologies, but which could coexist with different forms of a genetic origin, which is a paradigmatic reversal if we refer to numbers. The cases of keratoconus are overwhelmingly sporadic. In another recent study, we found that eye rubbing with the knuckles was the most important predictive factor for keratoconus, while the presence of a family history was not significant. Another argument argues in favor of an external factor for the genesis of keratoconus. If keratoconus is genetic, it should always be bilateral. Thus, the existence of truly unilateral forms is debated. Do they really exist? We believe so. Here is an example. The right cornea is affected by keratoconus, but not the left cornea. Negative for all topographical and biomechanical indices of detection. It seems, after almost 15 years of follow-up, that this keratoconus persists in remaining strictly unilateral. This is evidenced by the stability of the score and the differential map over 15 years. Obviously, the existence of strictly unilateral rubbing gives credence to the mechanical hypothesis, all the more so as the stopping of these from 2006 made it possible to stop the progression of the deformation on the right side. Many elements plead against a primitive genetic origin for keratoconus, the first being the large predominance of sporadic cases. Of course, there is a genetic dimension to keratoconus, but in my opinion it is indirect and concerns the degree of corneal resistance, for example corneal thickness or the quality of the stromal collagen, or even the susceptibility to allergies and all the factors that encourage patients to rub their eyes. Furthermore, the existence of a discordance between monozygotic twins suffices to discard the genetic root cause hypothesis. Here are 4 genetically identical eyes raised in the same environment, but only one of which has been excessively rubbed. A single case of such twins discrepancy is sufficient to demonstrate the need for external factors. Contrary to what is sometimes suggested, keratoconus is not inflammatory either. The inflammatory dimension of keratoconus arises from the potential causes of the eye rubbing, like allergy or dryness, and the consequences of the rubbing, like excretion in tears of inflammatory mediators in the event of friction. Inflammatory damage to the cornea is not complicated by a focal increase in corneal curvature, but rather by a reduction in curvature. Note how this cornea, however thinned, and with its biomechanics altered by infectious sequelae, presents a significant flattening of its anterior surface. Here is another eloquent example of post-inflammatory flattening of the anterior surface of the cornea despite significant thinning. This type of observation is common in clinical practice and can be used to refute, together with Marfan syndrome, this misconception that the softened cornea, but not victim of repeated mechanical trauma, thins and steepens, as observed in the course of the evolution of keratoconus. Subsequently, it is wrong to consider that keratoconus corresponds to an ectasia with a stretching of the corneal tissue. Indeed, we have recently shown that the area measured in millimeters squared of the corneas of healthy patients is not significantly different than the area of corneas with keratoconus of different stages. This globally isometric deformation disproves the mistaken concept of a major protrusion by progressive corneal distension in keratoconus. In this patient with a highly asymmetric form, the deformation and thinning of the cornea are evident, but there are no variations in the area of the anterior surface. The deformation is generally isometric, marked by a redistribution of curvature, but without noticeable expansion. This typical topographic aspect in no way corresponds to a protrusion or a localized protrusion, as obvious from the inspection of the photo taken from the side. It simply reflects an increase of the inferior keratometry, but also a major decrease of the curvature in the superior half of the cornea. This topographic pattern does not correspond to an ectasia of the corneal tissue. It relates to a globally isometric redistribution of the curvature without distension of the corneal tissue. In fact, the term corneal ectasia should be reserved for description of the morphological changes that the cornea undergoes in Marfan syndrome. The corneas are typically softer, thinner, but flatter. The dilation of the ascending aorta in Marfan syndrome is characterized by fragmentation and loss of elastic and smooth muscle fibers in the vessel wall. When the aorta dilates, the radius of curvature of its wall increases, which means that its curvature itself decreases. This is consistent with the mechanisms involved at the ocular level. The progressive distension of the eyeball affects the sclera, myopic shift, and the cornea, which thins and flattens progressively. This comparison raises the question, why do we define keratoconus as ectatic? Truly ectatic corneas are thin and flat. In keratoconus, the cornea is thin but steep, and this thinning and steepening are focal. The molecular mechanisms and the signaling pathways which would select a part of the corneal shell to thin and deform specifically and spontaneously, under the sole influence of the forces of intraocular pressure, have not been defined. Rather, the influence of an external mechanical force like eye rubbing is better at accounting for the characteristics seen in keratoconic corneas. The repeated rubbing years after years eventually causes a focal thinning and a subsequent biomechanical weakening of the corneal wall. In the earlier stages, the weakening of the central corneal causes a vertical sag down. This explains the frequent induction of against the rule or oblique astigmatism in the earliest stages, as the horizontal curvature is accentuated by a coupling effect to compensate for the vertical flattening in the context of an isometric deformation. After the presentation of these elements against the classical theory, it is now necessary to present the elements which incriminate the causal responsibility of the excessive eye rubbing. In 1965, the English statistician Sir Austin Bradford Hill proposed a set of 9 criteria to provide epidemiologic evidence of a causal relationship between the presumed cause and the observed effect. That can be useful in establishing epidemiologic evidence of a causal relationship between a presumed cause and an observed effect. Through this presentation, we will see that the hypothesis no rub no cone satisfies these criteria. Regarding the first 3, the literature abounds with articles where eye rubbing is always associated with keratoconus, which can be self-induced as a manifestation of compulsive rubbing behavior. We have discovered that in unilateral or very asymmetric forms, the most affected eye is always the most or the only one rubbed, and its side is highly correlated with the side or stomach sleeping position with prolonged compression of the orbit. Here is an example of a very asymmetrical or even unilateral keratoconus. The picture of the sleeping position was taken by the mother of this patient, who rubbed almost only his right eye. Here is another example, very similar. It is questionable whether this type of keratoconus could only be the consequence of a bad sleeping position, causing chronic eye irritation and subsequently the need to rub to soothe it. Let's focus on the 4th criteria, which is particularly important. When we question patients with keratoconus, we observe that in all cases, rubbing precedes the appearance of keratoconus by months or years. These actions are sometimes neglected or ignored, which explains why a small proportion of patients say they do not rub, at least at the first visit. In our experience, once awareness of possible excessive rubbing is raised, it is acknowledged by nearly 100% of patients during the second visit. This patient realized that he was rubbing his right eye harder, and we can safely assume that this explains the more pronounced character of the corneal deformation on the right. This relates to the 5th criterion. If it is difficult to draw a line separating the corneas affected by keratoconus and the so-called form first, it is because there is a continuum between healthy corneas and very deformed corneas. In the case of inadvertent topographic discovery of these early forms, rubbing is typically recent or much less vigorous and frequent. We recently published a study that shows that rubbing with the knuckles is worse, much worse, than rubbing with the softer pulp of the fingers. This continuum and correlation between gesture and severity of the deformation vehemently pleads for an external cause. In other words, the extreme variability of the topographic presentation modes of corneal deformation is matched only by the extreme variability of rubbing in duration, intensity, and frequency. A sleeping position on the stomach with the head resting against the eye sockets is very frequently found in patients with an asymmetric both eye, which, let us remember, is not an early ectasia, but an isometric warpage. Here is another more recent case of discordance in a pair of monozygotic twins, yet the resemblance is such that they each have the same iris nervus on the right eye. Asked about their sleeping position, the 2 twins said they slept almost exclusively on the left side, with their eyes often in contact with the bedding. However, the way and the intensity in which they rubbed their eyes was very different. The twin with the keratoconus rubbed vigorously with the knuckles. The other twin was rubbing much more rarely and gently with the pads of the fingers or with the sleeve. The 3 following criteria relate to the plausibility and coherence, occasionally confirmed by experimental evidence. The corneal resistance properties can be reduced by eye rubbing itself, and this is a mechanical route to keratoconus. But various biological mechanisms and enzyme cascades have been described in healthy volunteers who rub their eyes. Indeed, there is also a parallel rubbing-induced biological route to keratoconus. But that's not all. Until today, little was known about what happens to the globe when it is rubbed. We acquired dynamic MRI on a healthy volunteer who was asked to rub his eyes. These images speak for themselves. Chronic eye rubbing is compatible with the focal damage of the apical stroma, where researchers demonstrated, using Brillouin measurements, that biomechanical alterations were primarily concentrated. Beyond the corneal distortion, the movements of the globe, which steps back into the eye socket, are truly impressive. It is not surprising that cases of IOL subluxation, erythema, glaucoma, and retinal detachment have been attributed to excessive eye rubbing. We sometimes observe ptosis on the side of the eye the most rubbed, and this is not surprising since the eyelid also suffers the repeated trauma. Regarding the ninth criteria, the intraocular technique for presbyopia correction is a bit like an analogous model which shows that the selective severe incisional biomechanical weakening of the central stroma induces its immediate deformation. Another analogy, which is useful to dissipate confusion between direct root causal responsibility and optional risk factor, is that of the sunburn, which is more common in patients with a clear phenotype, but which absolutely requires exposure to UV light. As some phototypes are more UV sensitive, some keratotypes may be more rubbing sensitive. In summary, the Norum-Nocone conjecture meets the Bradford-Hill criteria. There is ample evidence that keratoconus requires an interaction with environmental factors to make a genetically determined predisposition manifest as a phenotypically apparent disease. This is where eye rubbing comes into play. We can assemble all these pieces of information to solve the puzzle of the pathophysiology of keratoconus, where eye rubbing, often associated with eye compression related to sleeping position, is a sine qua non. Finally, let us recall that the study of Marfan syndrome teaches us counterfactually that a soft but not rubbed cornea thins and flattens in a homogeneous and non-focal fashion. Therefore, it seems there is no way that the morphological changes seen in keratoconus could appear spontaneously in a weak but non-rubbed cornea. The reasoning and arguments used in this presentation have been partly explained in these articles. I hope that they will continue to allow a growing number of my colleagues to finally open their eyes to the causal and sine qua non nature of eye rubbing in keratoconus physiopathology, of which I hope to have provided enough convincing elements, while the current consensus is unable to account for reality and explain the mechanism at the origin of the deformation and thinning of the cornea. Future lines of research could help answer many open questions, including the following. From what rubbing threshold does the risk of developing keratoconus become significant? What are the mechanisms involved to explain the impact of sleeping position? How to prevent and remove the factors that cause patients to rub their eyes too much? Beyond the academic debate, refusing to admit the causal and essential role of excessive rubbing deprives us of the possibility of halting the progression of the disease or even eradicating it by educating patients at risk, particularly allergic or prone sleepers. I hope I have convinced you of the urgency to completely revise our understanding of keratoconus. Today, our care for keratoconus patients is fully dedicated to making them stop rubbing their eyes, which is not easy and requires a comprehensive approach. But that's another story. Thank you very much for your kind attention.
Thank you very much, Damien, for this outstanding presentation, and we all learned quite a lot. I may add, in terms of organization, that our visitors and followers from the 29th Kölner Adventssymposium are on the Zoom channel that has been online from the beginning of the day, and they follow us on our Cologne Zoom channel. So we have many followers and visitors here in Germany following these presentations. And our international guests are now following over the YouTube channel because we had some technical difficulties, but Chris managed to handle it, and she bypassed this technical difficulty by proposing the direct link into the YouTube channel. So if you have any questions from the audience, either be it from the international audience, you can use the chat in the YouTube channel. We can address these questions to the speakers, or our German visitors might address their questions in the Zoom chat. So there are options to ask a question at the end of the presentation session. We will try to address these questions to the speakers. But for now, I would like to continue with the second presentation. We want to first bring up all the presentations and then begin with a discussion, because I think we have the opportunity with 4 world-leading experts in the field, and we want them to discuss and look at the questions they have with each other and under each other. So I'm very happy and proud to present to you Professor Renato Ambrosio from Rio de Janeiro. Hello, Renato, how are you doing? You have to unmute yourself. We cannot hear you.
Oh.
Okay. How are you doing?
I'm very well. It's really nice to be with you. I learned a lot from Damien's talk, and I really look forward to this great discussion, the debate. It's been a very nice set, and thanks for the new technology and the new world that you are living in. So it's really nice to be with you. Congratulations for the setting up such a nice program.
Well, and you are contributing with your next presentation. I was lucky at the time to look at it yesterday. It's really great. As all the other presentations we are seeing today, they are really great presentations. There is Champions League format, and your presentation now is about multimodal diagnostics in keratoconus, keratectasia. Now, the special thing, I think, why it's going to get really complicated for us eye doctors is that keratoconus was an entity on itself. We have seen Damien with all the thinking behind it, how it develops and how it turns out. But now we have laser vision correction, which as well takes place on the cornea. So we have a kind of iatrogenic addition of a pathology, and the ectasia as a pathologic entity on itself makes the situation even more complicated. So I wonder how your approach is with regard to the diagnostic of differentiating keratoconus and ectasia and patients who maybe are at risk to develop ectasia when they're going to have their laser vision correction, which is a very, very popular procedure. So the next presentation I'm happy to present to you is from Renato Ambrosio, Advances in Diagnostics for Corneal Ectasia.
Thank you, Dr. Kermani. It's a pleasure to participate in this great session, along with many friends, on the debate about keratoconus pathophysiology, diagnosis, and management. So my topic is advances in diagnosis for corneal ectasia, and these are my financial disclosures. I'd like to start with some wisdom from Beda. The 3 paths for failure is not to teach what you know, not to practice what is taught, and not to ask what is ignored. So considering that, we need to understand advanced diagnostics for corneal ectasia. When we screen patients for ectasia risk prior to laser vision correction, we go beyond but not over the detection of keratoconus into the domain of characterizing ectasia susceptibility with enhanced screening tests. When we manage patients with corneal ectasia prior to keratoplasty, considering a paradigm shift, we need to understand what the patient has, the severity, using objective and subjective data, which is going to be the diagnostics for corneal ectatic diseases for personalized medicine as a different path than when we characterize ectasia susceptibility prior to refractive laser vision correction. This is truly an evolution that is a revolution in evolution. Multimodal corneal imaging, we have the what's and the whys, what we're trying to achieve in terms of what is the goal of your work in terms of screening, early diagnosis, prognosis, classifying ectasia, staging the disease, more detailed follow-up, which is important for patient orientation and education, and treatment guidance for refraction, contact lens fitting, customized surgical planning, and of course for the detailed follow-up. And we have multimodal imaging, and we have multimodal imaging in the algorithm with applied artificial intelligence and ancient intelligence, the philosophy, so that we understand the whys, so that we can take the advantage of these technologies for making the best decisions for our patients. We know that corneal topography enable us to detect ectasia, keratoconus, subclinical prior to the development of slit lamp signs and loss of distance-correct vision. Interestingly, ectasia is defined as a thinning disease, and the pattern, the thinning location, will be important for us to distinguish between a true pellucid, a keratoglobus, and an inferior keratoconus or a more global keratoconus. For example, the false pellucid here with the kissing birds with a vertical flattening against the rule of astigmatism with inferior steepening in this lazy C pattern is different when you have the thinning pattern of a false pellucid than when we have a true pellucid with this severe inferior band, which is pellucid, which is transparent, which is not opaque. There is no lipid degeneration, no vascular infiltration on the cornea, and you have this thinning pattern, which is important for us to identify true pellucid. When we think about diagnostics, we go for multimodal imaging, and we have many machines in the market. The Pentacam today has axial length and ocular wavefront, and this is going to be important for us to detect other situations, not only ectasia like angle closure glaucoma. And this data will help us to making clinical decisions in terms of lens surgery, for example. When you think about keratoconus and ectasia diagnosis and screening, we have the Bell Ambrosio with the enhanced elevation front and back surfaces and thickness profile. The D's are the deviation from normality, and the big D, the final D, is a linear regression analysis for optimizing the understanding of ectasia, even in subclinical cases. Interestingly, Michael Bellin also has developed the progression display, looking at the repeatability of the parameters, the radius of curvature at the thinnest point in the front surface and the back surface, and also the thinnest point. And you can see if this patient has a progression that is statistically significant considering the repeatability of the measurements within a keratoconic and a normal population, which is what we consider for the very mild cases. The number of publications and the interest on keratoconus have increased tremendously over the last decades, especially when we started with refractive surgery. We know that keratoconus is not a new disease. It has been very well documented even before, but we have the seminal work by John Nottingham that is probably the first good publication about keratoconus, and the role of refractive surgery for the diagnosis and treatment makes like a paradoxical influence, like is an ally or an enemy. Why? Because we have iatrogenic keratectasia. The first description of ectasia, for example, after LASIK, came relatively late in 1998, and the first cases are cases with high myopia treated by LASIK, in which the impact from the LASIK procedure caused iatrogenic ectasia. a few months later, still in 1998, iatrogenic keratoconus in a form-fused keratoconus defined from the front surface topography will be alluded to the progressive ectasia considering the abnormal biomechanical structure of such cases. Those two reports, they allude perfectly to the pathophysiology of ectasia, in which I would say is probably related to any disease in medicine, which is related to the innate properties of the patient and the environment. Considering ectasia, corneal properties are related to biomechanics, and the biomechanical decompensation cycle, nicely described by Cynthia Roberts and B.J. Dukes, will be related to the innate properties of the cornea and the impact from the environment, including laser vision correction procedures, but the more important is the eye rubbing, which is continuously done by the patient that causes the cornea to undergo ectasia, progression, and eventually the developing of the disease. A major point is that any cornea may develop ectasia, so that we tell people not to rub the eye, and it's a major message in our Violet June keratoconus awareness campaign that I invite all of you to participate next year, to tell people not to rub the eye. And eventually I invite you to understand that eye rubbing aggravates keratoconus and may even cause ectasia. Ectasia risk score system by Brad Rundle is a major contribution in which you look at the topography pattern as a surrogate of the corneal structure, along with age, which is a very good surrogate of corneal biomechanics, along with the impact from the procedure. And my humble consideration here is that form-fused keratoconus should not be a topographic pattern. Of course, irregular topographies are important, and the surgeon should know how to read topographic maps, but we need to go definitely beyond and not over the front surface of the cornea, and beyond but not over the understanding on what is form-fused keratoconus. So what is form-fused keratoconus? It was described by Mark Emsler many decades before topography was available. Interestingly, there are form-fused diseases not related to ophthalmology as described by the form-fused psychosis by Sigmund Freud. Interestingly, Yaron Rabinovitz would say that a form-fused keratoconus is the irregular topography eye from a patient that has normal slit lamp and normal distance correct vision. The fellow eye of this patient will be based on the editorial by Steve Kleiss in 2009, considered form-fused keratoconus. We have learned tremendously from those very asymmetric ectasia cases over the last years. And it's important to understand that topographic criterion is not going to be enough for you to separate form-fused from normals, considering this very nice scheme by Damian Gatinel. It's very important that you have, based on objective data, a normal and keratoconus separation, but the subclinical cases will fall in between, and we definitely need to go beyond, but not over, corneal topography. A nice systematic review of the literature found huge variability on the definition, the criteria for these studies, considering subclinical and form-fused keratoconus. In fact, there is no consensus, and my humble contribution is that form-fused keratoconus is not a topographic pattern, but should be defined as cases with high susceptibility for ectasia progression. In 2008, we took this paper at the AAO for the first time with this concept, and we are also debating about elevation versus curvature. Interestingly, this case was presented by Doug Koch, and I was able to get the data, the U12 files from the Pentacam, and do a detailed analysis. And a lot of people would say that this will be pathognomonic for form-fused keratoconus. I was really frustrated, and this consideration led me to the study on the variability of subjective classifications of corneal topography done by experts. So this is case number 6, in which we found a huge variability from 0 to 3 with a mode of 0, with the first scale, the 1.5 diopter Steve Kleiss scale, and with another scale, the half a diopter normative scale, we found also mode of 0, but varying from 0 to 4. Interestingly, this case was found with ectasia susceptibility because of the D that was higher than 1.4 and the artmax that was lower than 400. Interestingly, we have other cases published with the same scenario, like the SMILE case that developed ectasia, the first publication of ectasia after SMILE that has a biomechanical advantage, but you still cannot weaken a cornea that is abnormal. And we got the U12 files, and from the front surface, we were able to detect what we consider to be a low K keratoconus with many of the parameters that is abnormal. And I would say this type of table is very important for you to see the cutoff and the sensitivity and specificity for each of these parameters to develop the diagnosis of ectasia. So this case came handy as an example from the CareNet. The colleague took the picture from his smartphone, but we need to go beyond in the analysis. Interestingly, from the front surface, you have the differences in the aspect of topography if you change the scale. 1.5 diopter Steve Kleist scale. This is half of diopter, the classic ICs, which in the Pentacam is called the Holiday scale. We have 0.25, which makes this prolateness of the cornea more pronounced. Interestingly, we have the Ambrosio 2 scale, which is an absolute scale, and also the absolute scale with a half a diopter with a palette from the Atlas Humphreys Eyes topography. The topometric maps lead us to topometric objective data. In this case, has an abnormal TKC. Interestingly, the tomography, the thickness profile was abnormal in both eyes. You have also some abnormality in the quad map on the back surface elevation, and the BAD is abnormal, as it is the PRFI, which is an advanced function. However, this case will be considered as a bilateral form proved keratoconus, and we find those cases in some of the patients from the families members of keratoconus and other situations. But this is important that you go to understand what these cases are. It's not a keratoconus, but a susceptible. Another quote that I come to my mind is that we have to evolve always. And understanding that we need to evolve is that the D in a larger population with 105 ectasia cases in which we had the pre-op Pentacam, we got the sensitivity of 60%. Random forest analysis of the tomography data would lead us with a higher ROC with more sensitivity, but still with about 25% of these cases. Some of these cases are related to the impact from surgery, but it's clear that we have to go beyond, and we go beyond the analysis in corneal shape, considering segmental tomography with high-frequency ultrasound and OCT. The segmental or microlayer tomography allow us to see layers like the epithelium, the flap, the endothelium, the Bauman's layer, and this is pioneered by Dan Reinstein, in which he can identify thinning patterns in the contrast to thickening patterns when you have inferior steepening. There is a very nice algorithm that is done by machine learning using the Artemis, the ARC scan, which is high-frequency ultrasound, and we also have this type of data on the OCT with a pattern standard deviation that can separate a keratoconic cornea from a case of warpage. So based on the thickening here is related to warpage instead of a thinning here that is related to the mild keratoconus case. We have this summarized in this review paper in the Current Opinion of Ophthalmology in 2017, in which the role of corneal epithelium for the refractive surgeon is very nicely reviewed by Marcela Salomão. But going beyond the characterization of corneal shape, we have the characterization of biological properties, including wound healing and biomechanics. And I have a quote from Roberto Oliveira, colleague from Brazil, that this is an example from the past that never existed. But today we can do that with the Corvus. The Corvus takes in 31 milliseconds 140 images with a Scheimpflug camera. And this can separate a normal cornea from a weaker cornea based on the CBI, which is going to take into the consideration the deformation response and shape, the velocity, and all this data can separate if the cornea is softer or stiffer. Interestingly, we can have a PRK case presenting with the steepening on the front surface, and this patient was sent to me for considering a cross-linking procedure, and it is not ectasia after PRK. This patient has, in fact, haze, which should be managed completely different than a corneal ectasia case. Our idea is to combine tomography and biomechanics, and we have done that with the random forest approach as well, which is artificial intelligence can help us to separate from a normal population one eye randomly select for the clinical ectasia cases. 204 keratoconus cases, also one eye randomly selected, and we have 94 cases with normal topography based on strict criteria, and the 72 unoperated eyes that are fellow eyes of these patients. Some of these cases had the fellow eye done cross-linking, rings, or transplants. So this is a surrogate or an epitome for the biomechanical susceptibility. So we have an example here of a patient that has a normal topography and relatively normal DE, that the TBI is abnormal and the fellow eye has a mild keratoconus. And this will be a high susceptibility for this eye to develop ectasia. Interestingly, when we have cases with both eyes, like the 3 daughters of a patient that presented with keratoconus in Shizuoka Ko from Japan, the 3 daughters with normal slit lamp, normal distance correct vision in both eyes, all these 3 daughters have some abnormalities found in the tomography and biomechanics. Interestingly, the bilateral form fruits came in a very nice report from a bilateral twin sister with both eyes normal. The twin sister, the first sister, has a very asymmetric ectasia, and you see the TBI is abnormal in all the 4 eyes. Interestingly, this patient was analyzed by the AVA gene testing that found some of the genes that may be markers for keratoconus susceptibility. Ectasia can occur in only one eye. This patient was followed by Dan Reinstein after having corneal ring at my clinic. The left eye was very normal, and everything was still normal on the epithelial thickness and the Damian-Gattinel orb scan score, and this eye was considered as a unilateral ectasia, also based on the 2014 retrospective TBI that was still normal a few years later. So interestingly, we have the wisdom that true unilateral keratoconus does not exist, and keratoconus, while being bilateral, secondary ectasia can be unilateral due to the mechanical process. Interestingly, it can be even in both eyes, and then have to be keen to understand ectasia susceptibility and how the impact from surgery, considering surface ablation, femto LASIK, LASIK with keratome eventually, and SMILE or even fake IOLs, or if the patient has a disease and needs to have a therapeutic approach. Another wisdom that sometimes we know enough to think we are right, but not enough to know we are wrong. And with that, I come with the cases that were published, the studies that the sensitivity of the TBI will be much lower sometimes than what we previously published. And we know artificial intelligence is still in evolution, and with the optimized TBI, with a larger population, we were able to optimize in this multi-center study based on 25 centers that increased from less than 100 to over 500, so more than 5 times the number of cases that we have with normal topography from patients with very asymmetric ectasia. And we were able to improve the sensitivity about 10%, keeping or even improving the specificity. Interestingly, I have a case report here, just to finalize this talk, with a patient that presented with very asymmetric ectasia. How the exams can help us. Exams can help us first confirm ectasia in the right eye. This is a patient that has mild keratoconus in the right eye despite of 2015 corrected distance vision, and also in the left eye, not only because he was 13 years old, but because of the very low SPA1, which is the stiffness parameter at the first applanation moment. This patient has a high susceptibility for progression. He decided not to do surgery, even though I told him he should do surgery right away, which is something that I don't do for all cases. But you see the progression occur here. When we look at the Kmax, you may be misleading, but at subtraction maps, there is a clear stiffening in the zone, which is obviously very nicely detected by the ABCD. A final major advance is the Hamburg BEST display, which is a biomechanical evaluation that correlates to tomography, that you can see the progression of ectasia and even the regression after cross-linking. This is a must when we consider multimodal imaging, artificial intelligence applied with the hows and with the whys. So that is artificial intelligence and ancient intelligence applied for a customized evaluation for biomechanical susceptibility and all the keratoconic diagnostic screening, staging, prognosing, classifying, and detection of progression. So this is a true revolution in evolution. And I thank you very much for your kind attention. And I really look forward to the nice discussion that we'll have. Thank you.
Thank you very much. My partner Omid Kamani already said that we are going to discuss all the lectures at the end, so don't be disappointed that there are no questions yet. We are collecting them, and at the end we'll have that debate. Thank you very much for this interesting lecture. I learned a lot. And now we have, it's my pleasure to introduce, well, I don't know who's coming now, either Dan Reinstein or Timothy Archer. Okay. Hello, Timothy. Hello. Thank you for being with us. Timothy Archer is a head of the research department of the London Vision Eye Clinic, and I think there's no better person to introduce us now in the advantages in the early detection of keratoconus regarding epithelial mapping. So, would you do your presentation then now, please?
Yeah, absolutely. I think our presentation is also pre-recorded, so if you can...
Okay.
I'm going to speak about advances in the early detection of keratoconus with epithelial mapping. These are my financial disclosures. So let's start by the basics. Let's look at the epithelial thickness profile of the normal virgin cornea. We were the first to publish 10 millimeter wide epithelial thickness maps with 1 micron precision, and in accordance with the textbook statements about epithelial thickness, the central thickness was about 50 microns, but going against everything that had been published previously, the epithelial thickness profile is not an even layer. It is actually about 6 microns on average thinner superiorly than inferiorly, and about a micron thicker nasally than temporally, and you can see that right and left eyes have mirror asymmetry. Now, why is there mirror asymmetry? Well, I postulated in the early 90s that this was because of the eyelid anatomy. There is a tarsus, which is semi-rigid, a semi-rigid membrane in the eyelid, and this, I postulated, is what determines the curvature of the epithelium, because we blink 10,000 times a day, and this is an aggregate inward force and a shape which templates the shape of the outer shape of the epithelium. And of course there's outer force of the epithelium going from cuboidal to flatter to wing cells coming outwards, and it's the balance between these two forces that leads to a stable equilibrium, and therefore a stable epithelial profile, and therefore stable refraction of the eye. So we've published about 40 papers now just on the epithelium alone, and OCT publications are following along with many of the things that we discovered originally with ultrasound. But what we've learned is that the epithelium changes in all situations where you change the stromal surface curvature. And having looked at how the epithelium behaves in all these different situations, we set up a set of 4 basic rules about how the epithelium behaves and how it remodels after a stromal surface change. First of all, the epithelium thickens to fill any depressions. Second of all, the epithelium will thin over any peaks within the stroma. Third of all, the change in the epithelium will be proportional to the change in the stroma. So a higher myopic ablation will produce thicker epithelial thickness changes. More severe keratoconus will produce more marked epithelial changes. And finally, the amount of change is also defined by the rate of change of curvature. If you have a 1 millimeter wide but 200 micron deep depression from a corneal ulcer, practically all of this irregularity will be smoothed by the epithelium. But if you make, let's say, a 4.5 millimeter zone depression in the stroma by PRK in 1994, you'll get less compensation. And if you increase this optical zone to a larger amount, you will get even less epithelial compensation, as has been shown by original work, John Marshall's group with David O'Bart in the 1990s. So what we want to know is about how the epithelium changes in keratoconus, and this was something that I started studying a long time ago, having looked at ectasia and epithelial profiles. So the hypothesis of how the epithelium changes is diagrammatically displayed here. So in the normal cornea, you'll have a front surface, a stromal surface, and a back surface. So in keratoconus, the front and back surfaces are extruding, and the epithelium will remodel over the peak to become thinner, but it would also become thinner around the peak. Now, this particular donut shape is something which we described first in the JRS, a good old 15 years ago. The interesting thing, though, is when you have a very, very mild back surface yoked to a very, very mild front surface extrusion, but the extrusion of the front surface is minimal, and so the epithelium is able to fully compensate for that anterior surface extrusion. This means that you'll get focal thinning of the epithelium in a donut pattern overlying the back surface elevation, which is eccentric, which may, of course, get lost in the soup of statistical variation and therefore not signal keratoconus with enough sensitivity. Commercially, what has become of interest and what actually spawned the whole OCT epithelial thickness industry was when I demonstrated that you could have inferior steepening that could, with an epithelial map, be confirmed to be not keratoconic and rather due to thicker epithelium inferiorly. This means that in a study that we performed and published, 1,500 eyes, we demonstrated that 84% of the time, epithelium could exclude keratoconus in these highly equivocal back surface elevation abnormalities. And this, of course, then led to about a 7% increase in the inclusion to conversion for excimer laser surgery. So having studied the epithelial thickness profile in keratoconus and characterized that the epithelium becomes thinner the more advanced the keratoconus over the cone and thicker within the donut, we then sought to try and parameterize how in the very, very mildest keratoconic cases we could use or exploit this difference in epithelial modeling. So a number of publications have come out with the ability to demonstrate with OCT the difference between a keratoconic eye and a normal eye, but that's really not of interest because you can already diagnose keratoconus by topography. You don't need an epithelial map to confirm this. Well, Ron Silverman and myself obtained a NIH grant to do this study, and we essentially was one of the earliest machine-based identification pattern recognition studies from topographic maps. So to start this, we set up about 160 variables that we thought might be relevant in epithelial profiles with respect to keratoconus screening, of which 6 of them survived the model. And this gave us an exceedingly high specificity for keratoconus and one of the highest, in fact, I think the highest sensitivity at picking up keratoconus, which is understandable because a 1 or 2 micron thickness change in epithelial thickness profile, focal thinning in a region that shouldn't be having this focal thinning, is way more sensitive than a 1 or 2 micron elevation detected by a topographic or tomographic device with back surface mapping. So let's look at how this works. Well, of course, the epithelium profile can be used as an adjunctive tool in a case where you do suspect keratoconus. So here's an example of topography that was classified by the machine learning pattern of the Pathfinder on the Atlas as normal. However, it does look a little odd. And when you look at the back surface of the Bell and Ambrosio plot and the big D, you in fact confirm that this really does look like keratoconus. The epithelial profile, in this case, confirms that too. Here's an RT view map showing thinning focally where you would expect it from the back surface change, and here's the Artemis Insight. You can see that the values are actually different, and of course remember that epithelial mapping with OCT always includes the tear film. But you can have cases where there is both suspect topography and tomography. Here's an example where the topography has a small bow tie and the bad D is elevated with an extrusion on the Bell and Ambrosio posterior surface. But with the MS39, this doesn't appear to be the case on the normalized back surface profile. And the epithelium shows that it is actually quite normal. So depending on the device that you're using and the machine learning algorithms, you might actually think that this is a keratoconic case, but the epithelium will exclude that, both by the RSK score and just simple inspection of the epithelial profile. Now, cases where normal topography and normal tomography can be the scariest ones, because this is where the epithelium is your best friend. So here is a normal front surface topography. The Bell and Ambrosio, again, the bad D completely normal and nothing remarkable between the difference between back and front surfaces. But the epithelial profile shows quite significant focal thinning in the center of the cornea. And the pattern deviation map also shows inferior thinning where you wouldn't have expected. The RSK score in this case implies definitive keratoconus diagnosis, and this is a case where if you are only using topography and tomography, you may actually operate on this patient inadvertently. So this is keratoconus. Now, another example of normal topography and normal tomography. Again, small bow tie centrally. Pathfinder thinking that this is keratoconus, probably because of that pattern, but the back surface on the Bell and Ambrosio, again, normal. And the MS39 here on epithelial profile shows epithelial thinning inferiorly, which is coincident with the area where the Bell and Ambrosio looks slightly elevated. The ultrasound scan, which then this patient goes on to have, shows even more effect with this focal thinning, and it's quite mirroring the back surface Bell and Ambrosio changes. So again, epithelium saving the day in detecting keratoconus. And here's the other eye of the same patient, where the Pathfinder detects keratoconus because probably of the small bow tie. The back surface looks somewhat abnormal, but is not really being classified as keratoconic on the pentacam. However, the MS39 with thinner epithelium inferiorly does in fact coincide with the Bell and Ambrosio elevation, and the Insight 100 with more accurate epithelial thickness profiling, of course, confirming this. Different values, of course, because it, unlike the MS39, it doesn't include the tear film. But again, a case where we are detecting keratoconus where we may have missed it if we were just looking at topography and tomography. So the point here is that we're able to detect keratoconus with more sensitivity and therefore avoid false negatives when screening for keratoconus using only topography by proving that the epithelial thickness profile has the donut configuration. And this is exploiting the difference. But also, in cases where machine learning algorithms will classify a topography or tomography as keratoconic, and this can be proven to not be keratoconic by the use of an epithelial profile showing thicker epithelium over the zone where there is increased steepening. So let's remember, of course, that the epithelium is a dynamic layer that changes very easily with all kinds of conditions, and therefore contact lens warpage, anterior basement membrane dystrophy, tear film abnormalities, meibomian gland dysfunction, dry eye, and eyelid forces can lead to epithelial redistribution. So here's an example of a cornea that's been out of a soft lens for 3 days, looking very keratoconic, and here is after 2 weeks looking less keratoconic, and the difference is the epithelial remodeling. Basement membrane dystrophy, you can expect it to produce very abnormal epithelial maps because there's reduplication of the basement membrane and therefore thickening of the epithelium in zones that you wouldn't have expected it. So here's an example where the epithelial profile does show thinning with donut shape appearance around, and you might well just think that this is a keratoconic appearance because of that donut shape. Now, as a way of indirectly proving that it is the eyelid forces that cause epithelial thickness changes, you can see this friend of ours who has a Bell's palsy and is not blinking very much in one of his eyes, except when he voluntarily screws his eyes together. And so this demonstrates how in that right eye the epithelium is thickened significantly, producing a myopic shift in that eye, whereas in the eye that is blinking normally, the epithelial thickness profile is much more even. So, providing a template for epithelium in terms of eyelid, here's another example where the RSK score is keratoconic, but we know that from this that the eyelid anatomy of the patient is causing this thickening over where the epithelium is being thinned by the high-riding, tight lower eyelid. And this is producing a pseudo-donut, if you like, configuration, which is in fact not keratoconus. So again, you can't always go by machine learning. Let's just call the machine algorithms as a machine learning or an artificial intelligence assisted diagnosis. You still have to use your clinical factors in order to use the epithelium adequately for screening for keratoconus. So I hope that kind of covers the subject, and it makes it clear that performing refractive surgery without epithelial maps at this point in time, where there are multiple commercially available devices, seems like a fairly unwise way to proceed in this day and age. Thank you.
Thank you very much to Dan Reinstein, this exceptional talk, and you made very clear that epithelial mapping is a very helpful and good adjunction tool in the diagnostics of keratoconus and ectasia. Now, Timothy, you are holding the stick for Dan. He doesn't feel very well. I wish all the best for Dan, and he's back in office on Monday. But we accept it, of course. He doesn't feel well. That's why you're helping out. You are the technical director of the London Eye Clinic, and in the discussion, I'm sure you will debate with the expertise and professionalism that we are used from Dan. So thank you very much that you're jumping in. I have just one question for the audience. The epithelial mapping that we have seen here presented by Dan, that was high-speed ultrasound, or was it OCT?
So there was a bit of both in there. Most of the maps we showed were with the Insight 100 digital ultrasound, but we also showed quite a few maps with the MS39, the OCT from CSO. So yes, we're using both systems.
Yeah, both systems.
OCT, yeah.
So there are a variety of machines on the market in order to map the epithelium. It's widespread available. We will discuss this and some of the applications later in the discussion. Thank you very much for being with us. And I may now introduce Professor Farhad Hafezi from Zurich. And well, we all know him as for many years an expert in corneal cross-linking. He's a director of the Elsa Institute in Zurich. Farhad has 3 professorships, actually. He is a professor in Geneva, He's a professor in Southern California at the University of Southern California in Los Angeles, and he's a visiting professor in Wenzhou in China. So a man of many places, a man of international renomation, and we are very happy to have you with you. And your presentation now is about the advances in corneal cross-linking therapy of corneal ectasia, and later on we will discuss all the 4 presentations that we were privileged to follow today. Thank you very much for being with us, Fahad.
Thank you very much for your kind words, Omid, and I believe that you also have received my pre-recorded presentation.
Yes.
Hello, this is Farhad Safezi from Zurich, Switzerland, and I would like to thank Dr. Kamani and Dr. Gerten for inviting me to the Kölner Adventssymposium. The topic of my title is Advances in Cross-Linking Therapy for Corneal Ectasia, and these are my financial interests. Now, whatever cross-linking protocol we will look at, it is all about having these factors present. We need for every cross-linking procedure, UV light, riboflavin, and of course, oxygen. Now, looking back at how the whole field started in the early 2000s, we used a protocol that said 30 minutes at 3 milliwatts. That's the famous Dresden protocol, epi-off, with removal of the epithelium. Then, a few years later, industry proposed, why can't we do the same thing, the same total energy, but faster? Instead of 30 minutes in 10, 5, or even 3, if we adapt the intensity, the total fluence remains the same. That's the law from photochemistry. The question was, does this translate into clinical practice? So we tested the biomechanics of these different protocols, and what we found is, the blue one here is the Dresden protocol, very strong stiffening effect. The red one is 10 minutes. And as you can see, it is significantly less inducing stiffening than the Dresden protocol, but clinically, in most cases, this red protocol is enough to stabilize a keratoconus. But whenever I have a very aggressive form of a keratoconus, like a young child or an ectasia after LASIK, until now I went back to the 30-minute irradiation. Until now, because what we have identified after some years of research is another epi-off protocol that is accelerated too, but it compensates for a part of the loss in stiffness by increasing the total intensity. That's a very interesting protocol. See what happens here in biomechanics. This is the Dresden protocol, the one we saw before, 30 minutes. That's the 10-minute protocol that has less stiffening effect, all epi-off, and that's our new protocol. You can see it is at least equivalent to the Dresden protocol. It only takes 9 minutes 15, but at 18 milliwatts. I think this will be a very interesting epi-off protocol for the near future. Now, why do we have different types of reaction the faster we go? Because oxygen is a limiting factor. Oxygen needs to diffuse into the cornea, and it always diffuses at the same speed. We have 21% of oxygen in the air surrounding us. So if we make the cross-linking reaction too fast, the oxygen diffusion is not fast enough for the reaction to maintain, and we lose efficacy. Unless we compensate with something else, like, for example, increased intensity. This all was epi-off, and epi-off works nicely, but we all agree that the holy grail would be epi-on. Leaving the epithelium intact means much faster healing, less haze, much less infection risk, almost no infection risk, right? So let's have a look at the factors again. What do we need to make epi-off work? Because the quest for good, efficient epi-on has been going on for more than a decade. If the epithelium is on, then we need to increase our UV irradiation because the epithelium blocks part of the UV light. This is relatively easy. Up the fluence from 5.4 to 7.2 joule. Check mark. The next element is riboflavin. Getting riboflavin, which is a relatively large molecule, through the epithelium is not easy. One means to do it in past years was to use iontophoresis, which is an active transport using an electrical current. And lastly, the third element was only discovered in 2014 by my group, which is oxygen. If you have no oxygen in the cornea, there is no biomechanical stiffening at all. And this showed us that the oxygen content always needs to be given at all moments for cross-linking to occur. Now let's put this all into perspective. What would happen if you pulse the light, so light on, light off, with the idea that no oxygen is consumed when the light is off, oxygen can rediffuse. This was a proposition by industry which seems to be logical, but pulsing the light alone doesn't seem to be sufficient. We published on this in our laboratory results, and other groups have done the clinical work. So pulsing alone doesn't help. What else can we do? Well, if going too fast is not good, what happens if we go really, really slow in Epi-on? And this is what we did. We did a 1 hour irradiation instead of 30 minutes with half the intensity. So going very slow, and what happened? We published on that too. Very efficient Epi-on cross-linking. This is like a proof of principle, and as a scientist I'm happy. As a clinician, of course, nice, but I don't want to spend 1 hour in the OR, right? So what needs to be done to understand, but it helped us understand better what's happening in that cornea. Let's put this together. We know that pulsed light helps. We know that we need more fluence because of the UV light. And we know that somehow acceleration plays a role. And we know that oxygen is needed at all moments. So 2 to 3 years ago, there were other groups that said, well, if the 21% of oxygen around us are not enough, why don't we put goggles on the eye with 100% of oxygen, a stream of pure oxygen? Makes sense. It should work. I don't like it. Why? Because it's additional technology. And I want to simplify technology, not make it more complicated and expensive. So our question was, we don't need 100% of oxygen outside. What we need is enough oxygen in the cornea at all moments. And so what we needed was what I call an intelligent combination of everything we learned so far. And using normal air, the 21% around us. Is this possible? Oh, the answer is yes. If you put all these pieces of the puzzle together, you end up with a protocol that uses normal air, no oxygen boost, pushes the riboflavin into the cornea with iontophoresis, has pulsed light with a gentle acceleration, not too fast, high fluence. And this is no theory, this is a published protocol with a 3-year follow-up clinical data from Cosimo Mazzotta from Italy. Very nice study. He shows that Epi-on works. Now, looking at this again, what happened now is in Epi-on, we managed to remove the oxygen goggles, but we still need iontophoresis. So the question was, can we somehow do Epi-on without iontophoresis? Our group spent almost 1 year in the Swiss Federal Institute of Technology working on multiphoton microscopy and looking at how can we combine penetration enhancers so we end up with a riboflavin concentration in the cornea that is similar to iontophoresis, and we managed. Which means we now have an Epi-on protocol that takes relatively long to drop. It takes more or less 30 minutes, but this is the technical staff doing this in preparation, and then it has a 12-minute irradiation time. And this means that you can perform Epi-on at the slit lamp if you respect the role of oxygen. Epi-on cross-linking without iontophoresis, without oxygen goggles is here. So I can see how in very short time, in 1 to 2 years, we will do bilateral Epi-on procedures at the slit lamp in the procedure room. No infection risk. This was Epi-on. Let's have a brief look at thin corneas. What can be done in a cornea that is only 215 microns of thickness? Remember, 400 is needed in cross-linking because of the technical settings. How did we treat thin corneas in the past 10 years? Well, the treatment of thin cornea started with swelling of the cornea. That's the study we published from our Zurich team. So you swell the cornea with hypoosmolaric riboflavin, or you put a contact lens on the eye like Susan Jacobs proposed some years ago. If you ask me whether I use any of these methods today, my answer is no. Why? Because they both have disadvantages. Swelling is good in terms of biomechanics. The cornea reacts well, but some corneas swell a lot, others do not swell at all. It is unpredictable. And contact lens assisted loses 30% of efficacy. We published on this. Why? Because the best lens in the world, contact lens, is a barrier to oxygen diffusion. So, until now, if the cornea, that's the stroma, it's epi-off. If the cornea is thick, we cross-link down here with the safety margin. If the cornea is thin and we run into problems, we simply somehow artificially increase the thickness, right? We swell or we put a contact lens on the cornea. We somehow increase the thickness of the irradiation zone. What we propose now is what we call individualized cross-linking. For each patient, you calculate how much fluence is needed, no matter how thin they are, to never bring the endothelium into harm. So in other words, until now, we adapted our cornea to what we had as a technique. And that's not really a clever way to do so. We couldn't do differently 15 years ago. But what we can do now is we don't adapt the cornea to the technique anymore. We do the opposite. We adapt the technique to the cornea, which makes more sense. So this is what we call the sub 400 protocol. It has been published as an algorithm 4 years ago by our group. And then we went into a clinical validation study. Now the steps are standardized. You remove the epithelium, you apply riboflavin, and after 10 minutes of riboflavin, measure thickness by ultrasound. And this value you use to adapt your fluence. The algorithm and the clinical validation have been published in the American Journal early 2021. And then there is a table that tells you if your cornea is only 280 micron thick, use these many minutes to get a demarcation line on the right level. Theoretically, you can do this with any cross-linking technology, but in the technology we developed, the whole algorithm is integrated into the machine. So all you need to do is indicate the thickness, and then you will have the right treatment that automatically occurs. As I said, we did this study and we saw a very good success rate of almost 90% in corneas as thin as 210 microns of stroma. And this opened up a new possibility for a new indication, which is keratoglobus. We were the first to be able to successfully treat keratoglobus and stop progression of the disease with a follow-up of almost 3 years. So in conclusion, the future in ultra-thin corneas is what I call individualized cross-linking. You can treat down to 200 micron of stroma, and you can do this theoretically using all cross-linking technology. But we developed the sub 400 and we developed Epi-on for one reason. We want to share the knowledge, democratize access to cross-linking. So going away from an expensive infrastructure into the one infrastructure we all share, which is the slit lamp. And this is why we developed this little device. As you can see here, it's small, but it's full of high tech. It can treat at the slit lamp with over 11 different protocols for keratoconus, for refractive, for keratitis. So if you ask me how often do you go back to the laying position, I do. But for special cases like here, Down syndrome patient, general anesthesia, epi-off cross-linking. This is where I go back, of course, to the laying position, and you can use the same device for the laying position too. Questions came up in the last 2 years regarding cross-linking in the sitting position. What about riboflavin distribution? Does it go down with gravity? We tested this and we published. Short answer, yes, it changes, but you have 1 hour of time before the first changes become apparent, so more than enough time to perform cross-linking. Fixation, look at this video. Patient is absolutely stable. You can only see it's a video because the screen is flickering. Why? Because the patient is comfortable and they have a fixation light on the other eye, so they easily know where to look at. Is the patient comfortable? Can we do cross-linking at the slit lamp with the Dresden protocol, half an hour? Well, we don't need to. Cross-linking is around 10 minutes. Puck cross-linking for keratitis is around 4. That's easily feasible, especially if you give the patient the surgeon's chair, so they're really comfortable, and spend the extra 30 seconds in the beginning to make sure that the height is well adjusted. The last question is the most important. Can we go out of the OR into the procedure room or even into the examination room? Yes, we can. With epi-on, no question at all. Epithelium is on. With epi-off, when you perform an epi-off, you do not only stiffen the cornea, you sterilize the cornea. So the answer is yes, it's like an erosion coming through the door from the outside. That's probably more infectious than your cornea at the end of a CXL procedure. And also, if you have looked at the literature of the past 4 or 5 years, the trend is office-based procedures. Intravitreal injections performed In the procedure room, even in the examination room, there's a meta-analysis, more than 1 million cases examined, no increased risk for endophthalmitis. So yes, cross-linking should be feasible in the procedure room. The technique has been published, and this is what you see when you look through the slit lamp. It's very beautiful because you directly see the fluorescence. And these are just some impressions. Wheelchair access, very easy for wheelchair patients. So, in conclusion, cross-linking at the slit lamp democratizes access to CXL technology. It's suitable for all indications, epi-on, epi-off, keratoconus, PAC cross-linking. And I think that this represents the future of cross-linking. If you want to learn more, please come to our Congress. Registration is free. Last year we had almost 3,000 participants. And please follow me on Instagram. I will give regular updates on the technology. Thank you very much.
Wow, this was very impressive, Farhad. A very nice presentation. Thank you very much for sharing with us. And I'm sure the audience has enjoyed as well. There are many questions, of course. I think we have to discuss. I think I've seen Chris Morrill as well. Does she join us by now? Chris, are you there?
Yeah, I'm here. Omid, can you hear me?
Yeah, hi. How are you doing?
Switch computers around and everything works then.
Yeah, so let's get going into the discussion of this whole interesting topic, and I would like to propose that we start with the first presentation from Damien about the causes of ectasia. And I wonder what the opinion of the other experts with regard to the thesis is that Damien has risen. There's one mismatch I found in the presentation from Renato. He says there is no unilateral keratoconus. As far as I remember, you said so in your presentation, Renato. And Damien, if the cause of keratoconus in some eyes predominantly is a chronic traumatic one by eye rubbing, then, and you have showed a case with a with a keratoconus that was unilateral. So how does this fit together? I just want to bring up this this question in order to start the discussion get going.
Well, if I can answer something, I showed in my presentation that there is at least, but there are more than that, one case of strictly unilateral keratoconus. Some have been published in the literature. There is a paper also reporting on cases followed for more than 10 years. And the reason for that is very simple, is that if you don't, again, the problem with keratoconus is that there is no model that enables to show that if you don't exert a external force on the cornea, it will undergo the focal stiffening and weakening. And therefore, if you don't do this on the two eyes, but only on one eye, then you will have unilateral keratoconus. If you do it on both eyes, you will have bilateral keratoconus. If you do it more on one eye, you will have more pronounced keratoconus on one eye. And when you stop doing it, it stops. So this is almost elementary to me. Again, the biggest problem with keratoconus is that it's not a soft cornea to start with. Because when you have a soft cornea for other reasons like Marfan syndrome, the evolution is completely opposite to what we see in keratoconus. So this simple observation should make us step back from what we believe and consider keratoconus as a cornea which is made softer, or which softness increases focally because of this rubbing traumatism.
Renato, will you comment on this? Does this meet your experience? That would you say, if I find a case with a unilateral form frust keratoconus and I know that this guy is rubbing only his right eye, I wouldn't have problems to treat his other eye with LASIK, for example. Is it so solid? So that, I see Damien is nodding. Renato, what is your comment on the argument?
Well, I think there are two very different situations and points for discussion. First is nomenclature. And I think we have to be keen on nomenclature because we should work on that so that studies can be done
and we can follow those studies and we can learn from them today and 10 years, 20 years from now. So one issue is nomenclature, and we had a consensus that first, there is no consensus on what is form fluid. We fail to find a way to agree, and if you see the literature, there are many ways to define form fluid keratoconus. And forgive my French, fruit comes from French. It's confused, it's crude, is incomplete. So it's really frustrating to try to define what is form fluid keratoconus. But in the consensus, we were really finding easy consensus that keratoconus is a bilateral disease, but very asymmetric. In many cases, very, very asymmetric. The point is, even though keratoconus is bilateral, we can have like traumatic ectasia, biomechanically induced ectasia in only one eye. And actually, the point is sometimes the biomechanical ectasia can occur in both eyes, which is really hard or even impossible to distinguish. The point is what is cause and what is consequence. And I think we have to talk about the same thing. And Damian is very clever on his arguments, and I always learn a little bit from his ways of putting the ideas so that we really understand that eye rubbing is very bad for you. But I come to the conclusion that eye rubbing is important, but some people rub the eye and don't have keratoconus. So it should be explained by some level of susceptibility. So we have, as in any disease, we have susceptibility and environment. And susceptibility is from the patient, and environment is something that you can change. And eventually learning how to change and avoiding the environment issue, which is, in my opinion, really related to the trauma and eye rubbing and sleeping over the eye, are the most important causes for ectasia to develop or for keratoconus to progress.
Thank you very much for this contribution, Ambrosio. I have just one comment to make for the participants. Please put your questions if you're watching via YouTube in that top chat channel, and if you're watching via Zoom in the F&A section, so that we can read it. Thank you very much. And maybe one additional question to Damian. Sometimes I have patients, like neurodermitis patients, that rub their eyes, but they don't have keratoconus. So have you an explanation for that? So obviously not everybody that rubs the eyes gets keratoconus, or how can you, or have you done a study with people rubbing eyes, and what percentage of them get keratoconus and what percentage of them stay healthy? Is there something about that issue, or?
Yes, but that does not contradict what I'm saying. I'm very clear. It's not bilateral relation. This is why I take this sunburn analogy. When you go to the beach, not everyone will get a sunburn, although some people will. Those who will, they have a clearer phototype, etc. But the point is, and this is something we should not turn around, is that if you remove UV light, there's no sunburn, and my reasoning applies the same. So, of course, many people rub their eye, and a few proportion of them develop keratoconus. Those who do, I can tell you, because I have investigated this over the last 10 years a lot, and I have spent hours to discuss with some patients. They rub a lot. It's not that just a regular rubbing which leads to keratoconus. A few rubbing explains very well those form first, to bounce on what's said before. It's nobody will ever really draw a line between keratoconus and not keratoconus. It's like exactly you go to the beach and you start to decide who has sunburn, who has not. I mean, it's just a relation between how much you rub, how much your cornea resists to it. Some people rub not so often that their cornea is elastic enough, so it just dissipates the trauma and it will remain as it is. But after some time, then the cornea starts the deformation I described, which is a little sag down. That explains why when you have those patients, when they have 12, 13 years of age, they come to you and you find this against a slight vertical astigmatism. This is the first sign of keratoconus, because These patients, when you interview them, they rub more than the others, and if they stop, they will stay with this little irregular astigmatism, and that's it. So everyone who rubs too much may have keratoconus, but the point which is very important, and this in 11 letters, no rub, no cone, that means if you can have the population deprived from excessive rubbing, there is no keratoconus anymore. That's what I'm saying, and this is why it's so important, because this is a healthcare very important thing. And if you don't believe this, then I'm very open to ideas, but explain to me how the cornea deforms when it's not rubbed, because we have clinical evidences that when it is not rubbed and soft, it does not undergo the path toward keratoconus. So this is like a mathematical demonstration. But the argument that everyone rubs but nobody or not so many people have keratoconus is not making the theory invalid. Like, again, the sunburn analogy, which I take to explain very precisely my point, which is, again, it's like UV light, no UV, no burn, no rub, no cone.
Thank you very much, Damien. The multimodal...
Omid, sorry, can I ask a question? A follow-up question? Damien, is it possible, like the no sunburn, no UV light, no sunburn, but there are people who are more genetically predisposed to sunburning than not sunburning. So are there going to be corneas that are more genetically predisposed to developing keratoconus from eye rubbing?
Yeah, you can tell, like, what's very inherited is the corneal thickness you start with. So if you have a thin cornea, presumably you are more exposed to keratoconus if you rub too much. And that's why I'm saying, by analogy, that there may be keratotypes, and that's very nice to research those keratotypes. But if you are very pragmatic and think that the priority is to eradicate keratoconus, the first thing is to educate people on the way that they should not rub like this, et cetera, et cetera. Then probably we can find, doing experimental work, what is a threshold in terms of, when you smoke, there is like an amount of cigarette per day, per years. But that's way more difficult to quantify eye rubbing in terms of intensity, duration, and frequency than smoking. But still, there should be studies which try to evaluate this and correlate it to a certain risk of developing the disease. But of course, there are genetic predisposition, and I think the genetics is more important to allergies, behavioral, psychological conditions which make you more prone to rub when you have stress. When you work at night, also people who work at night are more exposed to keratoconus because they are tired, and when you are tired, your eyes are itching, and then you rub your eyes. So all these genetical, environmental things are leading to blame eye rubbing. The problem with keratoconus is that in this 1976 paper, the Beijing, they say 75% of the patient do rub their eye. Among the 25% who deny it, we can find on some of them relatives who say, no, you do rub your eye, etc., etc. And then they go to allergy that they found as a risk factor. And they discuss that allergy may make the collagen softer. They did not really see that when you are allergic, you are rubbing your eyes. And that's why allergy, pollution, dry eyes, dry air, etc., and thin corneas, like in the Middle East, in Mediterranean area, people have thin corneas, they live in a desert, it's dry, it's windy, they rub their eyes and there is more keratoconus there. But there is a genetic component which is probably linked to the corneal resistance that they start with. But if they never rub their eye, they would not have keratoconus. That's my point.
So we have a multimodal causative of keratoconus, of which eye rubbing could be, let's say, a fierce forcing power to start the process that we don't want to have started. Fahad, do you have to comment on this? I mean, you see a lot of patients from the Middle East, and as students already, what we learn in the textbooks is that keratoconus is something that is endemic in the Middle East countries, in Turkey, in Greece, in Iran, Lebanon. There are so many young people with keratoconus, much more than in northern European countries. How do you comment on this multimodality?
It is, and it remains a very interesting question. And maybe before giving my comment, let's go back to what we all share, I think, in this panel discussion is that eye rubbing certainly is something you should add on, by all means, avoid. I think this is anonymous between all of us. As far as I'm concerned, I have my difficulties with this simplification because on one hand, again, all of us have been seeing probably thousands of keratoconus patients in their career. And at least here in Switzerland, I have many patients that tell me, even upon repeated questioning, that they have never excessively rubbed their eyes. And I asked the family members sitting in the same room, is this true? Because sometimes the rubbers don't notice, and they say, no, they've never noticed anything, and still they have keratoconus. So for me, eye rubbing is an important risk factor, but again, as a cell biologist, I would like to see studies that go beyond a very nicely constructed hypothesis. And to me, it is a hypothesis that still lacks the scientific validation. And as long as the validation is not given, I have an issue with something that is as strong as a simplified slogan. So simplifying a complex disease to 11 letters that say no rub, no cone. I think we've seen in the past years that it is a human desire to simplify things when everything around us gets too complicated, but it carries a lot of danger. And I don't like that. I think keratoconus remains a multifactorial disease. What we have to be also aware of is that as much as we need to, and I speak to all eye doctors now that are listening to this panel discussion, as much as we have to educate our patients that eye rubbing is really not a good idea, as much we might have to slow down a little bit in the social media, because I have some colleagues that literally tell me, but it has already been proven that eye rubbing is the only cause. And this is where I start getting my problems if even colleagues start getting the knowledge from sources that are not necessarily Medline. And this is where we have to really, really step back a little bit and provide evidence. What we have done in our lab is creating, first of all, assessing clinically with the patients what is the force of knuckle rubbing, which probably is the most severe form, as Damian has taught us. And we took this force in Newton meters, constructed an eye rubbing device, and started rubbing ex vivo porcine corneas. And we did it with 10,500 repetitions, which should translate into 1 year of constant eye rubbing every day, multiple times a day. So we did this movement through the entire eyelid. So we had part of the orbit. It was not an isolated cornea. And what we found was very interesting, because biomechanically, nothing happened to these corneas. The stress strain measurement after 10,500 severe rubs was just as good as the eye that has not been rubbed at all. Then what I like about the study is it dissociates the pure mechanical force from the secondary effects that happen in a living organism, because I do believe that eye rubbing causes inflammation, and inflammation drives changes in the tissue that may increase the susceptibility or even kick off keratoconus. And this is where I do believe that inflammation is a key factor. So I would like to applaud Damien for his theory, but I would like to see more facts going beyond a nice MRI movie that shows us how severe it can be, but this still doesn't explain the causal relationship. Maybe you could have chronic eye rubbers that might be a little bit unethical to say, please continue rubbing your eyes, but take anti-inflammatory drugs to dissociate the two. But we need to better understand. We need some sort of clinical and also lab studies that shine more light into this relationship. And until then, I fully agree, let's stop rubbing our eyes, but I don't agree that this is the causal relationship, the only causal relationship.
Well, thank you very much, both. It's an ongoing discussion, and I just want to add something. When I have patients that rub their eyes, I always say them, if you have the need, or if you feel the need to rub your eyes, just take these drops, and I give them like lubricating drops. Is that something you can do?
No, of course.
I think it works.
There is a very nice video from Arthur Cummings that explains how to rub the eye, just pressing against the caruncula. And it is very efficient for the patient that has the eager to rub the eye, just pressing against the caruncula to not to rub the eye itself. I think there is no disagreement on the fact that eye rubbing is very bad, as Farhad very well pointed. But the point is, I also see a lot of patients that really, they say, I don't rub my eye at all, and I see ectasia to progress. So I think ectasia can develop even though the patient has minimally eye rubbing.
But how is it possible? I mean, if you believe in physics,
you have
eyelids. The force is so low. The force is about 2-3 newtons or even less than that. Rubbing is 10 times more. How can you have a tissue deforming? That's the point. I'm not saying. My theory is not opposed to another one. There's no theory of keratoconus that exists. This is the fuzzy consensus that the cornea self-deforms. I showed you that inflammation makes the cornea flatter. I showed you that Marfan syndrome makes the cornea flatter. So stop thinking that inflammation and soft cornea explains keratoconus. There's no alternative theory. I'm afraid to say so, to account for the deformation. The second thing is, before I came to this very simple thing, and you know, I'm a scientist, I will be the first to criticize someone who comes with a very simplistic ideas, and I'm really thinking, usually people know me because I think outside the box. So this time I think of very simplistically, because I can tell you something. I have patients who come to me, they are the relatives of people who work in the French government, in the healthcare department, and they have one child with keratoconus, and they have this indication for cross-linking. They have seen physicists who told them, do this, do that, and they come to me and they say, are you sure that if my child does not rub anymore, it will not progress? And I'm saying yes, and when they do this, they don't progress. So I hope that when we can publish these studies that I'm doing with my fellows, where we have hundreds of patients who are all stable and they are on the website, and we put that website on to convince people that when you don't rub anymore, when you protect your eyes at night, it doesn't progress. I hope the community will accept that this is the way more evidence to provide to the community than just ideas or reasonings. Some people tell you, I don't rub my eyes, but they do it sometimes unconsciously at night when they are sleeping. And if you have patients like this, give them patch to wear at night, and they will probably surprise you on the next day when they'll tell you, oh, I surprised myself rubbing my patch at night, it woke me up. So again, there's no way that the cornea deforms without an external force, because all other models fail to explain that. That's my point. So don't believe again that cornea deforms spontaneously, ectatically, because all other models that we have clinically, the Marfan syndrome, the inflammation, the traumatic things, when we have a trauma which takes away a lot of tissue, usually you know what happens. The cornea flattens eventually. When we had those camera inlays, we did a 250 thickness flap cut in the cornea. We put an inlay which triggers inflammation underneath. We put the flap back. What happens months later? Ectasia? No, flattening, causing hyperopic shift. So biomechanical weakening, half of the cornea is cut. You put a foreign body in the cornea. This is a recipe of keratoconus if I listen to you guys. And eventually what we have is a flattening. So stop thinking that inflammation or biomechanical weakening causes keratoconus, because the camera inlay is a recipe of keratoconus if you follow these rules. And we've never seen that, or when it happened, it was for other reasons. So again, this is a misconception.
Okay. Damien, thank you very much for your comment. I think with regard to the ongoing discussion, at least we have to say here's somebody who has a theory, and it is the good theory, actually. And all the others have a multimodal causative of keratoconus. So let's look at it from a different aspect. As long as your theory is there, you will continue to work on this, and and the other side has no, let's say, competitive theory on the cause of keratoconus as well, or at all. So I think it's a very good working start to educate people to not rub their eyes. I think nobody makes a mistake if we take care of this issue. We should not simplify. That's true, especially with the points that Fahad rose. But we need certainly, you open the door to a room where we find more doors that need to be open. Let's put it this way. Thank you very much for this one. But we want to discuss the other topics as well, and I want to go to the second talk Renato has presented on multimodal diagnostics in keratoconus. And I would like to point a little bit on the issue of biomechanics, because this also is a very controversial point. We have discussed with Dan Reinstein, and Timothy is taking his place. He will comment, I'm sure. But how specific, how sensitive is the biomechanical analysis of the cornea? And some people say it's nice, but it's very noisy. We don't have the specificity to rely only on the biomechanics of the cornea. How do you argument, or how do you see the future of biomechanics in the diagnostics of keratoconus?
We'll definitely evolve more and more with imaging, and biomechanics is part of the data that we have. We have Brillouin, which is very promising because you can map the cornea, and not only Brillouin, but we have phase shift OCT. It's a very nice work by DJ Dukes, that OCT can lead to information about corneal properties, not only giving the segmental layer shape. So we should be open to understanding that this is the true revolution in evolution. And I'm not here to say, okay, you have now a artificial intelligence index, and that's something that we should forget everything. The concept is to go beyond but not over. And sometimes I see a lot of passion in Damien, and I love to see this passion, because we learn from all this great interest, and I try not to get so passionate about the things that I am trying to prove, because even though I believe I'm trying to go in the right path for biomechanical and integrating with Scheinfeld imaging, I know that we in the basis is to go beyond but not over. To go beyond but not over biomechanics that we do today with better biomechanics, probably with integrated OCT technology. We have Brillouin that I don't have experience, but if you go back a few years ago, and Damien that's how I met and connected Damien about 10 years ago. We were talking about biomechanical assessments with the ocular response analyzer. And we had a huge overlap with corneal hysteresis, but then it got much better with the signal waveform factors that we can get from the ORA. And the shape that we get from the deformation is much more detailed with the Scheinfeld imaging. But the issue is that the IOP is probably the key when answer to what is going on for measuring the biomechanics of the cornea, because the IOP impacts the cornea deformation. We have a lot of examples in the clinical practice and some papers that in the contact lens, if you increase the pressure inside of the artificial chamber, the deformation is responding much more to the pressure than to the properties that are known from the lens. We know the properties of the soft contact lens that we are testing. So IOP impacts the biomechanical measurement with the deformation response, but also we know that cornea impacts the IOP measurement. That's why I say this is a bidirectional influence. The cornea influences the IOP measurement, and the IOP is going to influence the corneal measurement. And the true IOP, which is inside the eye, was going to affect the optic nerve in different patients in different ways. And I really believe that the corneal properties may reflect the scleral properties, and the susceptibility for optic nerve will be determined. Eventually, that can be also translated to retina, peripheral retina disease, because if you think about the very thin sclera, the extraocular muscles may lead to more pressure
inside the eye, and then you can have more issues with the peripheral retina and retinal detachment. So these are things that we are looking at in prospective studies. And I think multimodal imaging, this integration of data, is not one data is now going to replace everything. Considering epithelial thickness, and I'd like to hear very well Tim. Tim is a great scientist, and I have seen many of his great comments, even when Dendra Einstein is not able to come in the ESCRS meetings, with his opinion on what is the integration of the data with biomechanics, because epithelial thickness is definitely very important. We have many reasons for making it like as a must for any refractive surgery. In my opinion, for pre-op analysis, post-op analysis, epithelial thickness is unquestionable, very important. But the epithelium is by definition a reactor to the corneal shape. As then, and we have even a review paper that I put classically as Reinstein's law for epithelial compensation, thinning, thickening, and etc. All this are reactors for the corneal shape. So if you think about the evolution of keratoconus, you have a biomechanical susceptibility, which is triggered by genetics and environment. And of course, all of this will lead to some changes in the stroma and the diseases in the stroma. And this disease in the stroma will have a reflection on the epithelium, and curvature change will be like late if you don't, if you can't look at the stroma changes that we have. So I think we have in discussions like this, the ideas for many questions, and for these questions are going to be very important. And the beautiful study, the beauty of keratoconus is that we can help the patients unprecedented. In the past, we were only able to do a transplant, and now we have cross-linking rings and many other procedures that can help these patients to rehabilitate vision and to stop progression. So today, I think keratoconus is truly like a specialty for us refractive surgeons. It's part of the refractive surgery world, because we not only think about rehabilitation of vision, we think about progression of disease that we have to look at. And
thank you, Renato. Renato, I may ask our other speakers, Fahad, Damian, Timothy, do you use biomechanics diagnostics in order to look at your keratoconus patients, or is it it is not yet a practical diagnostic tool in your office? Are you all using biomechanical analysis?
Yeah, so we recently, about the last sort of 4 or 5 months, actually, we had the Corvus devices in the clinic. And I think what Renato was saying already is the key that we're finding over the last 20 years has been all the information you can add is helping us in detecting more cases. So certainly adding that biomechanical data is going to help. And like you said, it is more noisy than some of the other variables that we're using, but it's definitely adding something to the mixture. I just wanted to comment on something that Renato was saying as well about the epithelium being sort of it's reactive to the stroma. So I totally agree with that. The great thing about the epithelium is that because it's a thin layer, 50 microns or so, what makes it so sensitive, because now you're looking at a very thin layer. You can see more easily those very small changes that is harder to see on the stroma, on the stromal surface. So you can pick up those 1, 2, 3 micron changes on the epithelium, which is what makes it such a sensitive method for detecting things early. And that's interesting as well, which
Timothy, I was going to ask you about epithelial mapping later on. Let's okay. See what Damien and Fahad comment on biomechanics.
So I use biomechanics for refractive surgery evaluation more than for keratoconus follow-ups. And it's a bit a tiebreaker when you have sometimes those form first looking topographies. If there is, I use the ORA system, which I like. And when you have a signal, I look more at the signal shape than at the actual numbers, which are influenced a lot by intraocular pressure. So when they have low peaks and irregular peaks, it may be an indication of a soft cornea. And I think it's interesting to have this again as a tiebreaker. This reinforced myself to again explain the patient to stop rubbing their eyes and avoid after the surgery sleeping on their face, which I think if you do those two things, you reduce the risk of post-LASIK or PRK ectasia by a lot. So I use it, but not for keratoconus, because when you have keratoconus, it's too late.
Yeah, true. Farhad, I know that you're more in keratoconus than in refractive surgery, but does biomechanical analysis, is it a helpful tool in keratoconus assessment in a very early stage or in the progression?
Yes, I strongly believe so. The question is, how reliable is the technology that we have now, and how is it evolving? I used the ORA for 3 or 4 years, and since 2014, I've been using the Corvis, and I do not do my final clinical assessment based on the Corvis in my both my refractive surgery planning and my keratoconus assessment, but and frankly, sometimes the Corvis surprises me when I really can't put together what I see in topography, tomography, and biomechanics as delivered by the Corvis. But we perform it routinely because we are capturing a raw signal, and the better the algorithms will get in the future, the better retrospectively also old signals can be reanalyzed. Where I use it a lot is in screening. Every adult keratoconus patient is asked to bring their children if they have any. And here I find it highly interesting to see a quasi-normal tomography on an 8-year-old with a highly relevant pathological CBI. And this is where I base a part of my clinical judgment as to when to see back that child on biomechanics. I think the next step might be Brion or OCT-based elastography, and in about 4 to 6 weeks, that's a device Sabine Kling has developed at the ETH Zurich. We will measure the very first human beings here at the Elsa Institute doing OCT elastography, which should be an order of magnitude more precise than a Corvis measurement.
So with the increasing sensitivity of biomechanics, the new devices could develop to a helpful screening in children, young adults, in order to foresee what's going to happen later on if they have, let's say, a familiar problem with keratoconus, when they have allergies and the eye rubbing comes on top of it, so then things turn out to become very dangerous. Let's talk about Dan Reinstein's epithelial mapping, and he's very, as Damien is very focused on the eye rubbing issue, and he has promoted this very importantly. I think equally promoted the epithelial mapping as being by Dan Reinstein, and for decades he has been working on it, and for now we have several machines on the market. Timothy, this is, it seems to be a very important stepstone in your diagnosis, both in keratoconus and in ectasia diagnostic. If you look at the epithelial mapping from the clinical perspective, if the epithelium is so delicate, would that be a reason not to do, for example, topo-guided LASIK? Do you do topo-guided LASIK, or is topo-guided LASIK would be a procedure where the epithelium is anyway taking away the effect of whatever we do to the stroma in terms of microns?
Well, okay, this is a huge subject that we're getting into. So the epithelium and topography-guided LASIK it's quite complex. So topography-guided systems are deriving the ablation algorithm based on the front surface topography in most cases, right? So if you have an irregular epithelium, that means that the topography measurement can't see the irregularities that have been masked by the epithelium. And therefore, it will be less effective in eyes where you have an irregular epithelium. So primary topography guided is it's a bit different. I mean, because most patients have a reasonably regular epithelium, but some don't. There is variability in the epithelial thickness profile. So in eyes where there is an irregularity on the epithelium, that will throw off the topography guided algorithm, and you may end up with an outlier. Post-refractive, you know, where topography guided is used with the repair cases, this is where it becomes a major issue. So if you have a global irregularity, sort of like a decentration or a small optical zone, then the epithelial remodeling is more global. And so most of the irregularity shows through on the topography. And the topography guided treatment works very well. If you have localized irregularities, there's a lot more epithelial remodeling to mask those kind of irregular surfaces. And so the stroma, the topography measurement really can't see the actual irregularity on the stroma. And so topography guided treatments don't work very well and can often actually make things worse in those kind of cases. So yeah, the link between epithelial thickness and topography guided is very important. So you should not be doing a topography guided treatment without first getting an epithelial thickness measurement to make sure that it's reasonably regular. That's kind of...
Thank you, Timothy. Damien, what is your opinion on epithelial mapping? Is it so sensitive and so helpful in our daily diagnosis that we really need it, that we have to add it to our multimodality in diagnostic, or do you think, well, I could live without it? Do you use it?
Oh, of course I use it. I have the newest version of the Anterior Heidelberg system and have also the OptoView. So both are OCTs. My views on the epithelium is that clinically, I've never seen yet a patient for which the epithelium was altered from what you expect in a normal patient, and in who the cornea was not deformed on the anterior or posterior surface. What I'm saying is, I don't believe that there is a primitive deformation of the epithelium, although as again, eye rubbing is exerted directly on the epithelium, you may expect some things, but I think it's not that much obvious clinically to me. Of course, when you have a keratoconus, you have a specific pattern, usually has been shown a regularization pattern. What I think fascinating with the epithelium is how it knows, I would say, how to remodel itself. And if I was involved in epithelial research, and I have said that many often clinically, I would hire a real surface or a physicist or mathematician specialized in those things to understand what drives the epithelium to remodel itself. I know we blink 10,000 times a day, but still, how does this work? So, and what are the prediction of that? Because in refractive surgery, if you could predict how the epithelium will react to a specific profile of ablation, you could maybe more anticipate it. And I'm thinking of positive correction like hyperopia, because you know what's going to happen at the end. The epithelial feels the defects. And I find it fascinating that it does it probably in response to both biological and also physical elements like surface tension, like the minimization of something, you know, like when you put a drop of water on a surface, it takes a shape which depends on the hydrophilicity or hydrophobicity of the surface. But the shapes reacts to some physical laws. And for the epithelium, they are probably the same laws, but there are also other laws. And I would really do research in that direction. That the epithelium regularize the cornea is good, but how much and how can we predict it? That's really fascinating to me.
Well, Kanellopoulos performed hyperopic LASIK in combination with cross-linking, and he published that the results are more stable with regard to regression and stability. So maybe your point is absolutely valuable, and we have to go and look at this. Our time is running out, and I don't want to leave this wonderful discussion without going to the therapy. And Fahad presented to us a machine, a very fascinating machine. It seems that we're coming to a situation where where cross-linking can be performed in the practice room. It is can be performed anywhere in the world, at any place, any time. I'm sure our audience want to learn a little bit more about this technology. How do you soak the cornea in the sitting situation with the patient? You just drop him? And how do you make sure that in a sitting situation, when the patient sits at the slit lamp, that due to the position of the patient, the lower cornea is not soaked with more riboflavin than the upper cornea, just due to gravity? Is that an issue? And the second question would be, just to re-understand it again, epi-on or epi-off? You do the cross-linking epi-on with this machine, right? And how do you avoid the necessity of doing the iontophoresis? These two questions came up.
These are very interesting questions, and because this procedure is like any type of surgery, multiple steps that come one after the other, we looked at each step and tried to predict potential obstacles in the way. So first of all, we instill riboflavin in the semi-laying position. So a simple reclining chair where the patient is at maybe 20 degrees of an angle is already sufficient. Second thing is, then the patient comes to the slit lamp, is in the vertical position, and I've shown a study in my talk we published about 4 years ago, that from the moment on where the cornea is in the vertical, you have 60 minutes before you see the first gradient between upper and lower cornea. So you're right, Omid, there will be a gradient and more riboflavin in the lower cornea, but only after 1 hour, a 2% difference. So you have plenty of time. The third thing is, we cannot change too many paradigms at the same time. So this device is created to make the procedure simple, efficient, and democratize access. And you can perform any type of epi-off procedure. We have thought about how to remove the epithelium at the slit lamp for a long time, because even if somebody has been doing this with a hockey knife for years in the laying position, the movement of the hand in the upright position is very different due to the curvature of the cornea. So it is quite hard to remove the epithelium without cutting into Bauman's layer. And we finally came up with 40% ethanol that is on the tip of the cotton pad, and we tap the cornea. After 70 seconds, you have a beautiful erasure of 8 millimeters without doing any harm to the cornea. And this can be done by any beginner in the field. So the technology currently provides you with 11 different protocols that range from Dresden protocol via all types of accelerated epi-off to, excuse me, just a second, to various epi-on modules. And the way we avoid iontophoresis in epi-on was to go back to earlier studies that were performed by Italian groups and also by Edward Sperl on how to mix several penetration enhancers and modify the osmolarity of the solution to increase the paracellular transport within the epithelium. So the riboflavin can pass the tight junctions. And this took over a year, of almost 1 day every week or every 2 weeks at the multiphoton microscope. And we compared what can be done with iontophoresis in terms of riboflavin saturation, that's the benchmark, and how can we increase stromal saturation with riboflavin. And so it was just getting there in a painful process of modifying tiny things again and again and again to become better and better, and then to finally reach just as much riboflavin as iontophoresis would deliver. And this is where we are standing.
Thank you very much. Thank you all for this interesting contribution to the discussion. I have maybe one last question because we are running out of time now. We have covered a lot of diagnostics and a lot of causes of keratoconus, but we have not covered a lot of therapy. So my last question would be regarding the therapy of the keratoconic patients, because when they walk into our office, they don't say, doctor, please cross-link my cornea. They say, doctor, how can I see better? So this is, in most cases, their wish. And Fahad, you showed us, for example, these sub-400 protocol patients, and I'm fully agree with you. It makes a lot of sense to cross-link these keratoglobus, or almost pellucid marginal degeneration you showed us. But after that, for example, these pellucid marginal degenerations, they often have huge astigmatisms, but often regular. For example, would it be possible after a cross-linking to implant, for example, an ICL in a regular astigmatism, or would it be feasible to do intracorneal rings? And so combination, cross-linking and other procedures, that's one question I would like to give to the audience. Maybe everybody can have a short statement on that.
I might start. On one hand, you're absolutely right. Cross-linking the tissue might make sense to stabilize the tissue, but then we have to improve on vision. And especially in the thin corneas, this is a question we got a lot. What is it useful to cross-link a cornea of 80 diopters if the patient cannot see afterwards? Well, we are in the lucky situation in Switzerland to have 3 manufacturers of scleral lenses within 50 kilometers. And I have seen cases in our consultation that came from transplantation waiting lists with a cornea of 110 micron of stroma, residual stroma, huge epithelial compensation. Timothy would like these OCTs. And K readings of 160 diopters, 160, and a visual acuity of 0.7 with a scleral lens. This is just a miracle. So scleral lenses are, we have now collected a series of patients far beyond 100 diopters with really useful vision in daily life. So even these extreme cases can nowadays profit, and the best cornea is your own. So as long as you can preserve your own cornea, the better it. And for all the other aspects, I've been performing wavefront-guided PRKs on much less extreme cases for a number of years now to regularize the cornea, to improve CDVA. And this is where I like to know what the epithelium does in terms of epithelial mapping. It makes my trans-PRK much more precise. But I'm really interested in
Please let the others some time to comment on this as well, because I think we're running out of time. I'm really sorry. I would like to listen to you all the afternoon, but I think everybody would have the chance to. So you advocate for scleral lenses, and maybe Damian, how do you treat your thin corneas? What you do about them?
Well, I think for optical restoration, there's nothing better than a contact lens. So when I have a patient with keratoconus, I fight on 2 fronts: the cessation of the eye rubbing. So I give them patch at night, a lot of treatments. I go and send them to the allergy specialist, ask them to take care of their whole life to make sure that they don't rub anymore, etc., etc. That's one thing. For the visual rehabilitation, I'm very disappointed sometimes with like those segments or surgical procedures. At least that may be satisfying for the surgeon sometimes, but the patient is eventually dissatisfied because it doesn't really see the improvement. So I would more go for a hard contact lens. And as I told you, I don't really use cross-linking because, again, and that's why I'm confident in what I'm saying, else I would be in jail or I would be blamed by the patient that I follow. When they are really stopping the rub, they don't progress, and then that's time, sometimes even to do PRK on those who have just a minor astigmatism to correct for. As long as I'm sure that they don't rub anymore, I'm happy to do PRK on them, and or contact lens fitting, etc. That's how I do it. So I'm very conservative in terms of surgery with those keratoconus patients.
Thank you very much, Damian. So you advocate for stop rubbing and then maybe do a PRK, and contact lenses is a good alternative. So maybe the others, quick comments about that?
I have a very quick comment, and I can make it very quick. I agree, eye rubbing is very bad for anyone. For rehabilitation of vision, we have to go through the sequence, glasses, contact lenses, and imaging can help you tremendously with the scleral lens. And I agree with Farhad, scleral lenses are really miracles in many cases, but some cases need surgery, and surgery you go for rings, and patients are disappointed because eventually they have very high expectations. And the first thing in treating keratoconus is patient education. And patient education includes not to rub the eye, but goes very far beyond that. You have to tell about the disease, what they may expect, and the possible needs for the transplant. And I agree that even if you have a very thin cornea, if you cross-link the cornea, the transplant has a higher chance to be more stable in the future. This is not proven by a scientific study, but definitely we see a lot of patients late in the post-op after transplants, even adults, that may have some residual ectasia in the periphery. So I think cross-linking is a very good thing, even for a pre-transplant in some cases. A lot of people would debate because it may make the cornea harder for adults, which is not, I think, the case. But I think ectasia should be treated as a specialty, and we have to be very keen to respect the disease and not to oversimplify, because even though eye rubbing is really bad for everybody, I think many patients still progress. And if you ask me how, I can't explain, but the no explanation doesn't mean it doesn't work. And I have seen many cases that they promise me they don't sleep over the eye, they don't rub the eye, and they keep progressing. And those are the cases that we have to be prognostically detecting very early, because they need cross-linking very early, as soon as possible in many cases. So thank you very much for the opportunity, and I really enjoyed this conversation.
Thank you, Renato. This was a very, very nice final word, I think. We couldn't formulate it better. This was really a very terrific session, and I'd like to thank everybody who contributed with the presentation, with the organization here in Cologne, the Girling Company. I'd like to thank Chris for her support in setting up this event, and the debate will be continued with another topic, and Chris and you and I, we will look for the next turn and for the next topic. But for now, I like to say bye-bye. Thank you very much here from Cologne, and it was really good to have you with us. We have hundreds of German followers, but as well in the United States. And what Chris will make sure is this is all recorded on YouTube, that we will make this session available to public for everybody. So whenever you have time and feel that you have the spirit to follow the session or parts of the session, you can do it whenever you like, whenever you want on YouTube. Thank you very much. Stay safe, stay healthy, and it's good to see you soon again. And bye-bye from Cologne.
Thank you.
Bye.
Bye, everyone. Thank you, everyone.
Bye.
Thank you.
Bye-bye.
Thank you.
Ja, genau.